Going up. Hi, everybody. Hi, everybody. Welcome, welcome. Always good to see you. Lots of folks here. I know you guys know already to put your name in the chat box and all the people in the room with you. And we're just going to give people just a couple more minutes to settle in. And then we'll go ahead and get started. Just 1 minute or so, not too much. We have so much to cover. Oh, yes, people are putting their names in the chat. This is great. Great. Keep on putting those names in the chat box.
Hi, Doc.
Hi. Look at that. All these people. Come on in, settle down. Okay. While you're settling down, I'll go ahead and do the little intro slides as usual. Welcome to Echo. Next slide. Free, free, free. Convenient in your room. Learn from each other. Ask all the questions you want. No question is a dumb question. They're all good questions. Okay, next slide. And of course, you know, we're going to keep everything confidential. Don't share any patient names or birth dates. Actually, it worked out really well. If you have any questions that you want to be anonymous, you can just private chat Michaela, and she can read off the question without having to name your name. And so that's perfectly fine too. Questions or comments. And yeah, so you guys know how to use the chat tool. Enter your name and others joining with you in the room today and hit enter. And then there's the mute button. Make sure it's on when you're not speaking, and then unmute it to speak. And of course, we love to hear your voice too. And we are now on session 3 out of 4 parts, addressing what matters. Next slide. And in order to get your certificates of attendance, CMEs, and social work continuing education credits, there will be a link in the chat box towards the end. Just click on it and answer the questions and you will get your certificate. Next slide. Okay, and just quick introductions. You know me, Wanette's here. Say hi, Wanette.
Aloha. Hi. Thank you for joining us today.
Awesome. And Maribel's here.
Hello, everyone.
Great. And is Juliana here from Aloha Care?
No, this is Steve from Aloha Care.
Oh, Steve,
Yeah.
great.
Dr. Land.
Great to see you. Thanks for joining. And is Shane able? I know Shane was having trouble getting on. Did you succeed, Shane? Or is it Lila here? Lila Ventar.
Hi, Dr. Red, I'm here.
Good to meet you.
I'm trying to open my video, but it's not letting me. Oh, there we go.
I see you. Okay, great. Okay, fantastic. And of course, everybody else, just put your name in the chat. Okay, next slide. Oh, wait, here we have our guest speaker to introduce, Hope Young. She's from Kakua Mau, and she's a total expert on advanced care planning documents and stuff and how to fill them out. So she's the go-to person to ask all your questions, and she will be doing the presentation today. Next slide. Okay, a little bit on COVID. We were hoping it would all be gone by now, right? But not quite. Next slide. So now they're just tracking it on a weekly basis and taking the average daily cases per week. And as of a few days ago, the 18th, the 7-day average cases were around 193. So it's just kind of creeping up a little bit more every week. So got to be careful out there. It's not quite over yet. And then also just want to point out that we have a pretty good vaccination rate here in Hawaii. Pretty much 77.1% of the population has received their primary series of shots, and about a third of folks have received a booster in addition to that. Next slide. So this is another website, the COVID data tracker website that talks about community transmission. And basically you can see that it is still substantial to high. So we really do, we're not quite in the low or moderate range. And unfortunately the cases continue to rise and our percent positivity is up to, you see the newspaper this morning, Honolulu Advertiser, right? It was like 7.1%. So be careful out there. It's not done with us yet. Next slide. So just as a reminder, in case you need to be encouraging your staff or your families and visitors, booster shots are available to everyone 12 years and older. That's for the Pfizer. And you get that about 5 months after completing your primary COVID vaccine shots, the first 2, that's your primary, and then you can get your booster 5 months afterwards. And then after your first booster, you're considered up to date with COVID vaccinations. And then people who are vulnerable, if they're immunosuppressed, or if you're an adult 50 years and older, you are also eligible for a second booster. And this second booster can happen 4 months after your first booster. So just to clarify. And then also the same, pretty much the same rules go for Moderna, except that instead of for 12 years and older, it's for 18 years and older. So if you got the teenagers in there, you can get them the Pfizer instead of the Moderna. Next slide. And if the person got the Johnson & Johnson vaccine, that's just the 1 shot and you're done. If you're 18 and older, and you got your Johnson & Johnson, you can get the booster shot at least 2 months after getting your first one. That's your first booster, and then you'll be considered up to date. But you can also get a second booster, but the second booster shot has to be an mRNA vaccine. So it's got to be either a Pfizer or Moderna. And of course, 50 years and older, or if you're immunocompromised. Next slide. So why get a booster? Because it prevents you from getting severely sick or being hospitalized. I mean, it doesn't prevent you necessarily from getting COVID in the first place, but if you can not get hospitalized or get severely sick, then that's a great thing. It also makes you less likely to spread the virus. So that makes me, hopefully then you won't feel quite as nervous or anxious about it. And then, of course, with the whole mask mandate going away, you know, it's going to be up to us. You know, we're going to need to choose whether or not to wear a mask because it's not mandatory. But just a reminder that the relaxation of indoor mask mandates, as well as the mask mandates on planes and public transportation and things like that, does not apply to healthcare settings. We are all in healthcare settings. Indoor mask mandates still apply. So everybody who comes to visit in our facilities needs to wear a mask. You know, the COVID variants, these new ones are still very contagious and it's still spreading. And now on average, we have about 190 cases a day. And I do know that there are facilities with outbreaks at this time. And we're setting up those COVID units again. So be careful. And even if you don't get severely sick or get hospitalized, if you get a shot, and you wear a mask, it makes you less likely to spread the virus to those with weaker immune systems. So, so we have to, so this lady here, she's still wearing her mask and she got a booster too. So make sure you can do that. Any questions on boosters and masks?
Is that necessary for us to get the second booster shots?
If you are 50 and over, yes. It's not mandatory, but it's a good idea. Because
Okay. Did you did yours?
I did.
Okay.
I did.
Thank you, Doc.
Yeah, no, it makes you less likely to spread the virus to others with weak immune systems. And if you have your own weak immune systems or taking prednisone for if you have an asthma flare or something like that, then you won't, I don't know, feel as nervous or guilty, I suppose. if
Fast
you're around
question.
people. Yeah,
I have a question. Can we mandate the visitors to the care homes to wear a mask?
yes.
Okay,
In fact, you can ask them to leave if they don't. Because it doesn't apply to non-healthcare, to healthcare settings. It
thank
applies,
you.
the indoor mask mandates only, I mean, the relaxation of the indoor mask mandates only applies to, like restaurants and stores and those kinds of other settings. But healthcare setting, hospital, nursing home, care home, I think a care home is just like a nursing home. It's a congregate living situation full of vulnerable seniors. So I would say, yeah, this is a healthcare setting. Sorry, the mask mandate still applies in here. Otherwise, you guys can visit outdoors.
Thank you.
Dr. Wen,
Yes.
can you review the definition of immunocompromised, because they recommended it, and then when we went to get the second shot, they said, oh, that's not considered immunocompromised, having diabetes.
Yes, that's right. Yeah, diabetes makes you vulnerable, but it's not immunocompromised. Immunocompromised basically is if you are like a cancer patient getting chemotherapy, or you have like rheumatoid arthritis and getting the immunosuppressive treatments and things like that. Diabetes, unfortunately, does not count, as it's a vulnerable population, but doesn't count as immunocompromised. Okay, any other
Thank you.
questions? All good questions. All right, you can still put all the questions in the chat box if you think of any as we go along. I'll be happy to go back to them.
Dr. Wen,
Yeah,
can I just inform everybody that for DHS, we had a meeting last Tuesday. They said that the pharmacies that went to the foster home, care homes, are not going to go to the homes until August or September. So anybody who wants to get their second booster shot can go to the pharmacies and get it.
Oh, okay. Wow. All right. A little more effort. But sometimes that's what's required to take care of each other, right? Go the extra mile for your friends. Okay. All right. Next, I think we're gonna, I just wanted to throw this. Only a note on boosters for children. Only children ages 5 to 11 who are fully vaccinated and immunosuppressed can get the booster. So they don't otherwise get the booster. But Pfizer announced that it plans to submit a request for emergency use authorization for children 5 to 11, but it's not yet approved. So stay tuned. It might get pretty soon. So hopefully the kids and the grandkids can get their boosters. Next slide. Okay, so I just wanted to take a couple minutes and think about wellness. We take it for granted. I mean, we're caregivers, that's by nature. So we never give ourselves a chance to take care of ourselves too. So I just want to make a few comments on wellness. 4 things: rest, restore, create, and connect. So allow yourself to rest, not just when you have time to rest. I mean, I'm guilty of that too, right? I don't have time. Well, sometimes you need to just draw the line and you have to fight for it. Say, no, after whatever dinner, I'm done. Don't bother me, right? I need my rest tonight, so find coverage, draw the line. You need to fight for your rest. Otherwise, it's not going to happen. And sometimes you have to allow yourself to rest. Easier said than done, because I know everybody struggles with rest, right? Like, what's that? And restore, random acts of kindness helps restore your faith in humanity, and it boosts well-being. So even though it seems like, well, Well, it takes effort to do stuff for other people, but I'll tell you, if everybody sort of does a little bit and just reaches out with little acts of kindness, it's going to make a huge difference. So I'm going to challenge you guys to reach out to your whole household, your whole team, and say, hey, everybody, this week is Random Acts of Kindness Week. Let's see how we can outdo each other. And maybe everybody can be a little happier that week. And then creativity has been shown that also increases your sense of well-being. So it takes creativity, right? I mean, to have fun, right? So try small, it doesn't have to be huge things. It's small things. It's the rascal things that you do sometimes, like my son does sometimes, you know, that if you just add a little bit of small acts of creativity every day, that can go a long way. It won't help you create more time, but it'll just make you feel a lot happier during that time. Okay. And then connect, just rekindle, or sometimes it's hard to make new friends. I mean, you know, you only have so much bandwidth, but your old friends, old relationships, rekindle or strengthen them. Don't have to spend a lot of time. Just a little text, a little smile, send a little heart. Good enough, right? And then hopefully can add to that little by little. So these are important to put back into your life. And I'm going to encourage you to choose one of these and then do it this week. We have to do something and we can't create more time, so we can do one of these things. So, and yeah, if you have ideas for any of these things, please put it in the chat box, comment on it later. All right, next slide. Okay, now we're up to the what matters, addressing what happened, what matters most. And so I'm going to hand this off to Hope and take it away. Thank you.
Thanks, Dr. Nguyen. Aloha, everybody. So nice to see your faces. My name is Hope Young, and I am the Advanced Care Planning Coordinator for Kokua Mau. Hang on now. There we go. And Kokua Mau is a 501c3 nonprofit community benefit organization. We are statewide, and we aim to make healthcare, we aim to improve we're a movement to improve healthcare. We want to improve the way that folks are receiving care out there in the community. And how do we do that? Well, we do that by education and awareness, and also by preparing folks with the documents that they can benefit from completing so that they get the care that they would like during any times of health crisis or at the end of life. So advanced care planning, that's what we're talking about today. And before I go into this, I'd like to just put a poll out there. And if you folks could just drop it in the chat box, if you already have your own advanced directive, I'd like to see how many of you actually do. If you do, just go ahead and put it in there. I got it. I hope to see the numbers on the little chat bubble go up. So if you don't have your advanced care planning done and you don't have an advanced directive done, this is definitely something that I'd encourage you to do for yourself. Great, I see some people saying I have it, yay. So why is this important? Well, no one really plans on becoming very ill. Nobody knows when that's gonna happen, right? Anybody, dementia planners out there, with all the work that you've done with your residents, anybody planning for their own experience, getting older or possibly having dementia or emergencies, things that might come up in the future? For those of you with your camera on, you can just wave if you do, if you have. For the rest of you, if you don't have a camera on, you can drop it in the chat box. But this is why we do it, because nobody really knows when we're going to become very ill, right? This is an opportunity to help your loved ones find your voice during a time of crisis. It assures that your wishes are followed. It's also important to ease the burden for others that may have to make tough choices on your behalf. How do we do that? By making sure that your wishes are known. And we have to convey that information with our loved ones. And not only for you yourself, and I'm going to ask you to wear two hats today. One is you yourself as an individual who should be doing advanced care planning for themselves, but also as a care home operator, with thought in mind for those families that you're providing care for and those people who are living within your home. So keep that in mind while we're going through this. Again, if you haven't done your own, we're going to encourage you to start with your own first, so that you could probably have a better idea of how to facilitate these conversations with your residents. Woody Allen has a great quote. His quote is, "I'm not afraid of death. I just don't want to be there when it happens." And you know what? I appreciate that. I really do appreciate that thought, because I'm right there with you, Woody. So if the unexpected happens, who would speak for you? And would they know what you would want, or possibly what you don't want? And now keep in mind, how would they know? The only way that they really would know is by having these conversations, right? So again, it's really about communicating what's important to you and making sure your loved ones know how to support you during a time of crisis. Did you know that everyone over the age of 18 should have an advanced healthcare directive, which names their healthcare agent? That's also called the healthcare power of attorney. I interchange those two phrases often. I also call that person your champion and your advocate. This is the person who has been trusted to make decisions on your behalf. Without an advance directive, some of you may know this can be kind of difficult. Without an advance directive, precious time could be spent trying to figure out who's in charge. In the state of Hawaii, there's no next of kin type of situation. So just because they're married, it doesn't mean their spouse is the automatic decision maker. Just because they have adult children, it doesn't make them the automatic decision maker. What they do here in Hawaii is, if there's a need to figure out who's in charge and find out who that agent is, they're going to call a meeting, and they will call all the interested parties, meaning anyone who's interested in talking or representing the person that we are trying to find an agent for. They will ask all those individuals to come together and decide who's in charge. Now, that can be a real challenge. Anybody with a family knows that every single family member has their own opinion, and that can be challenging. So if you have families that maybe they don't necessarily agree, this is a good opportunity to get this paperwork done and completed so that an agent can be named. Because what happens is, if they can't come to an agreement amongst themselves, then there is a possibility that it becomes a guardianship case. Now, prior to the pandemic, it would take about 6 months to resolve a guardianship case. Now we're hearing anecdotal stories that it's taking 8 to 12 months to get guardianship cases resolved. So it can take a long time. Guardianship is not very cheap to go through. It does require getting a lawyer, going in front of the courts. So rather than having that be the course of action, it's best to be proactive and actually name your agent, your healthcare power of attorney, on a document. And it's really a gift for those loved ones that want to be there to support the individual. And for this presentation's sake, you are the individual that we're referring to for the most part, because I want to encourage you folks to do it first. Now, this is a type of planning, and we know that lots of people do a lot of planning. I've had conversations with kupuna that will tell me, I have my estate plan done, I have my will done, I have my trust done, I have my make box with all the clothes that I'm going to wear, I have my burial plot, I have my songs planned out, which is all amazingly awesome. That's great. That's great planning. And we want to encourage those folks who have done that to take it a step further and plan while they're still here, because all of these things that they've already planned for don't actually take effect until they've actually died. So how about we plan prior to that, so we ensure that their life all the way up until time of death is the life that they'd like to live. So that includes health planning, personal planning, legal planning, financial planning. Advanced care planning, I'd say it also comes under not just health, but also personal, legal, and in some cases, it could be a financial thing in the background. So Kokua Mau, we offer a free advanced directive. It's free to download. It's on our website, kokuamau.org. You can print it out, fill it out, and that's great. And we'll talk more about how to make it a legal document. Advanced directives can only be completed while someone is of sound mind, which is why if we have any dementia planners out there, this is why we do it while we're healthy and able to make decisions. because it's a two-part document. So the first part names the healthcare power of attorney, the agent, the person that is trusted to make decisions on behalf of the individual completing the document, as well as directions for them. So it's the two-part document. First part is naming the agent. Second part is what's important to them and what kind of decisions should be made for end-of-life decisions. So the first section is naming that healthcare power of attorney. Who do you trust to make your healthcare decisions when you cannot? Say you've been in an accident and you're unable to speak for yourself. Who do you trust to be able to make decisions while you're unable to do that, while you're unable to speak for yourself? Well, the person you choose, it should be somebody who's familiar with your personal values and willing and able to make decisions on your behalf. It doesn't need to be a family member. You can choose a friend, you can choose a cousin, you can choose somebody that you trust, but you also want to choose an alternate. Alternate is the second person, and keep in mind, having that second person is really important, because if you're in the car with your first choice healthcare power of attorney and there's a car accident, there may be a need for a second person to step up and take that role. For this document, it only becomes effective under certain circumstances. If I have an incurable, irreversible condition that will result in my death within a relatively short time, if I've lost the ability to speak for myself and communicate my wishes, or if the likely risks and burdens of treatment would outweigh the expected benefits. So keep in mind, there's certain things that have to happen before this document takes effect. And the first choice on this is, I want to stop or hold medical treatment that would prolong my life, or I want medical treatment that would prolong my life as long as possible within the limits of generally accepted healthcare standards. Well, that's a lot of words, and sometimes, it's a lot to take in with that thought. What does it look like? What do these two choices look like? So when we say I want to stop or hold medical treatment that would prolong my life, essentially you're saying you don't want to have medical intervention to prolong the life. You don't want to be, possibly you don't want to be in a hospital setting. You'd prefer to be in a setting of your choice without that medical intervention to prolong the life. Second one is, I want medical treatment that would prolong my life as long as possible within the limits of generally accepted healthcare standards. What does that look like? Well, if you've ever visited somebody in the ICU, that is generally accepted healthcare standards. And we've come so far that medical advances are able to keep an individual alive using medical intervention. So there is a possibility to prolong life with medical intervention. It doesn't mean that they're going to last forever using that medical treatment, but it does mean that they can prolong life. And however, if they are near to the end of life, it may not be enough to keep them alive for a long period of time. So again, you want to decide which one would you prefer. And it's a personal choice. This is an opportunity to open a discussion as to why you've chosen either of these treatments, either of these directions in your path through your healthcare journey. It gives the opportunity to discuss more about why. Next section is on artificial nutrition and hydration. And we like to just point out that here in Hawaii, food is kind of love, right? We share food with each other. Food is a sign of aloha. If you've ever visited somebody while they're cooking dinner, oftentimes they'll just say, here, take a plate. If you go to a luau or a party, they'll say, here, take a plate, take it home. We're the home of the plate lunch, the mixed plate. That's how we've created that, by people coming together and sharing food at mealtime. So it's really important to recognize that this is an important part of your document as you complete it. And it's your personal and individual decision. So would you want artificial nutrition and hydration if you were unable to feed yourself? So I'd like to share the story about my mom. When she found herself at the emergency room, Mom had Parkinson's, congestive heart failure. She had bad arthritis, and she didn't have her medications. And we're not sure how long it was that she didn't take her medications for her Parkinson's. And for Parkinson's, as most of you may know, you can't swallow well. Part of the affliction of Parkinson's is oftentimes they're unable to swallow. So she hadn't gotten her medications, she hadn't eaten, and for that reason, she was weak and she had a fall. When we got to the ICU, actually we got to the ER, and they figured she was dehydrated, she needed some extra attention, and they moved her to the ICU. So in the ICU, the nurse came with the artificial feeding tube and asked mom, let's try and do this, and mom agreed. And so what they did was they did an NG tube, and simple, what that looks like is it went up the nose, down the throat, and into the belly. And that's how the nutrition would be given to her, so that she could get a little bit more sustenance in her body. So the first time they put it in, it went up the nose, down the throat, and into the belly. And she immediately said, "Get it out, it hurts." So they took it out, and they came back a few hours later. Again, put it in, check the placement, make sure it was in the right place. And she immediately said, "Get it out, it hurts." So by the third time they came in, she was not having it. And she told them, "Get that away from me. I don't want that anymore." During this time, she was still trying to take in food by mouth, at least kind of just tasting a little bit and trying to get water in her. But because she was still alert and aware, although her paperwork said she wanted to try artificial nutrition and hydration, she was still in control of her decision making. And so she decided not to do the artificial nutrition and hydration. But keep in mind, they will always try to feed by mouth whenever possible. And it is an individual and personal decision. In some cases, it can prolong life. Some people have lived years with a PEG tube and tube feedings. In other cases, it may not prolong life. It may, in fact, prolong the dying process. Think of the body as needing fuel. And if the body is slowly shutting down at the end of life, it no longer needs the fuel. So it can prolong the dying process. It can also be kind of painful if they are getting food nutrition when they really should not be. Next section is under relief of pain and other important considerations. Pain is one of those things that it's a personal thing, what you would want to do, whether you would want pain medication or whether you prefer not to have pain medication. This is another opportunity to have a discussion on why that would be. If you're completing your documents, this is an opportunity to tell your healthcare agents why you would or would not want pain medications. And then what's meaningful to me, what's important to me. This is a part where you can actually write in your own words what's important. This is where you can write in there, hey, if I can eat chocolate and watch my Korean soaps, I'm good to go. That's great. Or, hey, if I've got dementia, please don't chase me around the house trying to get me to take cholesterol pills. Give me the ice cream and let me be happy. This is where you tell in your words what you want your agent to know about the care that you'd like provided for you. This is also where you're able to put in, if you want a trial support, how long you would want it for. And also where you can say, please stop any medical interventions if this happens. So really, this is an important part to put it in your words so that your agent is able to navigate your decisions with you first and foremost in mind. In order for this document to be legal, it must be either notarized or 2 witnesses. Now, witnesses cannot be, it must be over the age of 18. It cannot be the person named as the healthcare agent. It cannot be a healthcare provider or an employee of a healthcare facility. So if one of your residents are trying to get their document signed and they need a witness, you are unable to do that. As the healthcare provider that they're receiving care from, you are not eligible to sign as a witness. So that's something to keep in mind as well. And one witness cannot have inheritance rights. So I'm going to pause briefly to give you folks, if you have questions, you can drop it in the chat. We'll have at the end of this, we'll go through Q&A, but just so that it's clear in your mind, if you have any questions right now, go ahead, and we'll ask Michaela if she can kind of pull those out for us to discuss later. Next document is POLST. And I'm sure anybody not familiar with POLST? I don't see any heads. I see a lot of yes, sweet. Oh, I see. Oh, Miriam saying yes, right? You know what it is. Is that what it was? I saw Shaka. Okay. So again, the bright green form. It's the provider's order for life-sustaining treatment. Now, it is important to recognize that this is not a required document. So even though you have people in your home who may qualify for this, this is not a required document. Who would benefit from having a POLST form? Someone with a chronic or progressive illness, somebody who's considered medically frail. They may have a serious health condition. They may have a wish to not have CPR. They would like a do not resuscitate order. Another question you can ask yourself is, would you be surprised if this resident died within the next year? If you said, no, I wouldn't be surprised, then they might be a good candidate for POLST. And POLST in Hawaii, we have one form. Again, the use is not mandated, but honoring that form is. The form itself provides immunity from civil or criminal liability. So that protects you as the care home operator, that you are honoring the wishes of the patients, which has been discussed with a provider. Now, your provider is either the physician or the APRN who signed the document to make it legal. In 2009, it was first introduced into the state of Hawaii. And in 2014, it was updated to include APRN signatures. So nurse practitioners can now sign off on the POLST as well. First part of the POLST, simple enough, the name of the person that it's for, some information about them, birth date, and the date the form was prepared. And on the back of the document, it has the patient's preferred emergency contact or legalized authorized representative. Now, ideally, that person should be the same person that is on the advance directive. So that would make that the legally authorized representative. That would be that person's healthcare agent. Now, if that person is not available, but they have been named on the advance directive, you should just clarify and make sure that that is the person that they would want contacted in case of an emergency. First section. Okay, I'm going to ask you all to get your typing fingers ready. We're going to have a quick quiz. For the first section, it is about CPR. The person has no pulse and is not breathing. Go ahead, tell me what they are. In the chat, drop it in there. If the person has no pulse and is not breathing, they're not conscious, what are they? Any takers? Be brave, it's okay. Full code. Any other answers? Unresponsive? Anybody else? Dr. Wen? There we go. Anthony got it. They are dead. They are dead. If they have found someone who has no pulse, they're not breathing and they're not responsive, they are dead. So this first section of your POLST form is asking what to do if we have found someone and they have died. So do you want us to attempt CPR? Do you want us to attempt CPR, or would you like us to allow a natural death? And I like to use that language because saying do not attempt resuscitation often doesn't sit well with people. It sounds like we're not going to do anything, but actually we are doing something. We are allowing for a natural death. So again, the first section is strictly on CPR. Do we attempt CPR? Do we initiate the CPR? Or do we allow for a natural death? Next section. This is when the person still has their pulse and they are breathing. What level of care do we want them at? So there are 3 different levels that are described in section B. We have comfort measures, limited additional interventions, and full treatment. Now, the difference between the three levels, comfort measures, oftentimes these are for people who just do not want to go to the hospital. They possibly are in hospice. They just want to be kept comfortable. And the next level is limited additional interventions. These are folks who are okay with going to the hospital in case of an emergency, but they would rather stay out of the ICU. So we're going to be making decisions to try and avoid the ICU. And then full treatment, these are the people who are saying, yes, let's go to the hospital, let's try everything. And this is a choice. This is a personal choice that the individual should be making for themselves or with their legally authorized representatives helping with that decision making. Now, if the individual says, yes, I want CPR, they will automatically go to full treatment. If they say, you know what, let's allow for natural death, they actually have the option of choosing between comfort measures, limited interventions, and full treatment. Now, some might say, well, why is that? Well, CPR, it's the standard response. So that would be protocol. If EMTs are to come, that would be what they'd start, CPR. But in order to support somebody, if they're able to resuscitate them, they would need the support from medical intervention, which would be full treatment. So again, if they have CPR that they'd like, then they are automatically, and the only choice that you have is full treatment on section B. If they're allowed natural death, they can choose any of those three options. Next section, we're back to food, because you know food is love. This is the opportunity on the POLST to determine what course of action folks would want with artificial nutrition and hydration. So they could actually say, I don't want that, I'd like it, or I'd like it for a trial period of time. Additional notes can be made on that additional orders for the providers so that there's some clarification if there's any question. And we always offer food by mouth and liquid by mouth as long as it's feasible and desired. So who can sign this? Who is responsible for signing this? Well, first, again, you have the APRN or the physician and their legally authorized representative. That would ideally be their healthcare power of attorney, the person they've named as their healthcare agent on their advance directive. That's the legally authorized representative. But also it could be signed by the parent of a minor. It could be signed by a patient designated surrogate. That's where the patient themselves say, I want my daughter to be in charge. And they've done this in front of medical staff who is able to document that in their medical records. And then the surrogate elected by consensus of interested parties, that's when we bring that group of people together and those folks come together and they decide on who's in charge. Or it could be signed by the guardian. Now, with the non-designated surrogate, the person that has been named as that authorized representative by the group, they have a little bit of limitations on it as far as what their authority is. So that is on the back in section E to name who that non-designated surrogate would be. And this is for people who lack capacity but have not designated a healthcare power of attorney. So this is when you would use that non-designated surrogate. When that group has come together, they've named that person, and that's where we use that. They recommended to be printed on lime green paper. I'm sure you've seen it all over the place. We put it on the refrigerators. If you have many people in your home, you might have a special place in the room for them. But make sure that it's someplace where when EMTs, first responders come on site, they are able to do a quick scan of the room and they can see it immediately. So you want to make sure it's someplace that they can see it. Oftentimes you want to have it right by the bed if you have multiple people who have a POLST in the home. Ideally, if you have a POLST and an advance directive, we recommend that you get a plastic sleeve and you put both of them together so that when it comes time to transport the patient, they are able to have their advance directive and their POLST ready to go with them. So here's a snapshot, and feel free to take a picture of this in case you still kind of are gray with what the difference between the two documents are. Advance directives are intended for everyone every competent adult over the age of 18. This is for a future, we're looking into the future for future healthcare decision-making. In your advance directive, it's appointing your healthcare representative. This is not a document that can be handed off to EMT as something they can follow. And also, it's also important to notice that CPR and the allow for natural death is not addressed in the advance directive. Whereas the POLST, it's for a person with serious illness at any age. It indicates the decisions about current treatments right here, right now. If there is an emergency, what will we do with this individual? This is where you can name the legally authorized representative. It can be noted on the back. And it's important to note that first responders are able to take that POLST and use that as actionable orders because it has that signature from the APRN or the physician. This is also where the CPR and allow natural death is addressed. So if you need to kind of refresh your memory or maybe keep it somewhere safe, feel free to take a picture of it so you can review it later.
Okay, so if you don't mind, there's a couple
Sure.
of questions in the chat that pertain to this diagram, I think.
Okay.
And it would just be good just to, hopefully this helped clarify your questions. The question was, if a client has no advance directive provided, is POLST enough to have in a client profile?
That's a great question. And you know, I would strongly encourage to complete the advance directive to support the POLST so that you can name the individual who takes that authority role as the healthcare agent. So if a client comes in with a POLST, by all means, encourage them to complete the advance directive. It should also be noted that you can complete the advance directive with just the first half, naming the person that you would like to be the healthcare power of attorney. And so that can be a completed advance directive that can go hand in hand with the POLST so that they have that person, that individual noted on an advance directive so that they have authority to make decisions on their behalf. That's a really great question.
And then the other question is, I am a caregiver and can I make my own POLST?
Well, for clarification, as a caregiver, do you mean for yourself or for the individual that you're caring for?
I think she's referring to herself.
Okay, so
As
if
a
you,
care home operator for herself as a caregiver, does she need a POLST?
okay, well, again, with the POLST, remember it's a certain demographic that we're looking for, and it's not a real broad thing. We're trying to really discourage people from using POLST just because someone's of certain age. We want to ensure that folks have some of these ailments. Either they're seriously ill, they may, have a chronic illness. The question is, would you be surprised if this individual were to die within the next year? And if the answer is no, I wouldn't be surprised, then that's a candidate for the POLST. Now, if you as a caregiver are thinking because of the CPR part of it, then absolutely you can go and talk to your physician about it. If you're thinking, I just don't want CPR, this would be in lieu of, before they used to have those medical bracelets that said, do not resuscitate. We no longer have those bracelets. So this is why they've changed it to the POLST form. So again, back to your question, it really depends. Do you fit the criteria of needing a POLST? Whether it's because of health illnesses or the desire to not have CPR, then you would be a candidate for it. But if it's just because you're a care home operator, then that's not necessarily a good reason to give yourself a POLST.
Okay, another sort of related question, right? I was told by PCP that if a resident has refused interventions via the POLST and he or she is in acute distress, like choking to death, the care home doesn't or shouldn't respond. It doesn't sit very well with us. Is that true?
So if they're choking, there's nothing on the POLST about choking. So you want to address the fact that if they are choking, you want to try assist them and clear the airway so that they don't, stop breathing completely. So I agree. It would not sit well with me if I'm not sure what to do with that. But if it's a matter of choking, then I would say go ahead and assist because that is not due to natural causes, that is due to something that they've eaten, they've ingested, and it's now causing some issue.
Okay, great. I'm gonna let you finish your talk and then there's a few more questions.
All right. Oh, I love it. This
Gotta
week
go
has
fast.
lots
We got
of
lots of
questions.
questions. Lots of
Yeah. Okay. Okay. So where does the POLST fit in? Back to where do we go? We start with the advanced directives at 18, and we want to make this a fluid document. We want people to keep coming back to it. We don't want them to think, hey, I completed it, I'm done. I never have to think about that again. We want you to go back and review it from time to time, whether it's because of a new birth, a new marriage, a divorce, maybe a new trip, a new diagnosis. Keep coming back and reviewing it and just make sure that it's still aligned with what your wishes are. And then once someone is diagnosed with that serious illness or chronic disease, that's when we want to consider getting that POLST in there so that on the treatment wishes are honored. Can POLST be changed? Absolutely. An individual with capacity can request alternative treatment and revoke the POLST at any time. So like with my mother, she had her advanced directive and she had her POLST. Because she was able to tell me what she wanted, it didn't matter what was on either document. She was still in charge of her care. So it is very important to recognize that as long as the person has capacity and is still able to voice their opinions and requests, they are still in charge of their healthcare decision making. The legally recognized decision maker can request changes based on condition change or new information regarding patient wishes. So it can be changed, it can be updated. If you have a POLST, a new POLST and an old POLST, you want to cross the old POLST out, void it out, put it back in their patient records, whatever you want to do with it, but don't have that as the first line. You want the most recent POLST available for first responders. POLST conversations is really an opportunity to increase the awareness of different courses of action that they may be facing because of their illness. It is also an opportunity to introduce palliative care and hospice and what those are. And it really gives you the opportunity to change the question of what's the matter with me to what matters to me. Because what matters to me is how I'm going to decide what matters, what decisions and healthcare decision making I may want to ensure that I'm getting what matters to me. And so I'm going to finish off these slides and I'm take us down and then we can finish up with these questions. We have resources that are free for you to download at Kokomo. All of these have been translated into 10 different languages. So if you do have somebody who English is not their first language, you can go and check our online list of resources to see whether or not they have these translated into a language you may need. We are working on getting additional translations and we hope to have them by the end of this year. This is my information. Go ahead and feel free to take it down if you have questions. Please don't call me at 2 o'clock in the morning because that's not gonna work for me. But if you have questions about advanced care planning, the advanced directive or the POLST, that's my contact information. Again, I'm Hope Young. And the Conversation Project is a great resource that we encourage folks to use if you're trying to facilitate having these conversations with your clients, if this is something that you would like to ensure that they have.
Okay, great. Hope you had a happy Easter. Okay, got a bunch of questions and I think some of them got answered, right? One was that, do you have to renew the POLST every year? And does the POLST ever expire?
Good questions. No, you do not have to renew the POLST, but we would strongly recommend you review the POLST every year, at least. I do know of some care home operators, they have put it on their calendars twice a year to go through every resident's documents to make sure that everything is up to date. We just had April 16th was National Healthcare Decision Making Day. And that is one of those dates that you could put on there. It's right after taxes. It's a national thing that folks are encouraging people to do advanced directives and advanced care planning.
I go ask her.
Okay. If you put it on your calendar, you can remind yourself and that would give you one opportunity and then do another one later on in the year, maybe around right before Thanksgiving, give you that opportunity to update it with family members coming to visit as well.
And also anytime there's a change of condition.
Absolutely, yes.
Right. The similar question is, how long is the advanced care directive effective?
It's actually, there's no limitation on either of these documents, so you can go ahead and do it comfortably, but just keep in mind that as conditions change, people's what's important to them may change as well. So it is important to recognize that, hey, these are documents that you want to make sure that it is reviewed from time to time to ensure that their wishes are known, one, and two, that the person that they've named as their agent is still able to be their agent and decision maker, and they still want that person to be that. Some of our older kupuna, sometimes they put a spouse down, and then after the spouse has passed away, they still have that person listed. So it gives you an opportunity to review it and make sure that it's still up to date.
Very good. Quite another good question. POLST can be displayed. Can it be displayed or it needs to be visible? Isn't it a violation of HIPAA?
Well, this is interesting. So part of HIPAA is, if you're looking at it from the EMT point of view, they are not, unless you go up there and read it really good, it's not a violation of HIPAA. You could also put a sign saying there is a POLST and where the POLST is located. If you're really not sure about it, you could say POLST is located in top drawer and have it up if you're really concerned for patient privacy, but it is not a violation of HIPAA.
Okay, great. And if you have a living trust, I think the advanced directive and POLST are included.
Well, living trust is kind of an old term. It's kind of old as to say like living will. Advanced directive includes those living will type documents, but it also adds that naming the agent. So some people who have created trusts or living wills, it may say the agent, it might not. Oftentimes with trusts and living wills, those were done with lawyers, so it might be a bit longer. So it's really good to just go back and review it and make sure that it's what they want. And again, our document is free to download, so they don't have to go back to a lawyer to change it if they want to make any updates or edits to the documents that they already have. They just do a new one.
Great, thanks. Okay, John, next slide. Okay, so 3 things to look for, right? We'd like you to look for. One is that general, in their advanced care documents, the general power of attorney, did they name someone? And then number 2, in that advanced care document, there is a section regarding their wishes. And so that's number 2. And then the third thing to look for is that POLST form. Do they have that? And so those are the 3 things we'd like you to go through every resident in your facility, in your home, and see, do they have 1, 2, and 3. Next slide. Okay, and so, whoops, yeah, whoops, there we go. And so we would like, if you could, we have to justify our existence in some way. So we'd like to show that we have some impact. And so if you could just share with us, how many residents do you have? And then how many of them have that power of attorney, that advanced care planning wishes documented, and that POLST form? And so, yeah, so after you complete your evaluation, there will be a link to share how many of these residents have these 3 documents, and have somebody try to screen all of your residents before the next session. And if you try to complete this, that will really help us demonstrate that you are doing a good job helping residents achieve their wishes. Next slide. I'll let Michaela chime in here.
Yes, so it's like Dr. Wen said, you complete your evaluation like you do every month. For those of you who have joined us all the time, I just placed the link in the chat box. So follow that and complete one evaluation for everybody that wants a certificate of attendance. If you have 3 people watching with you, 3 people have to complete the certificate of attendance, because we use a system, an online system that will send you it with your name filled in. Then you will receive an email confirming that you have completed your evaluation. There'll be a link in there for you to go give us information about your advanced care plans and POLSTs. We really, really, really appreciate you providing this for us. We need this to continue to get funding so that we can provide these to you free of charge. So I know it's a lot every month for us to ask for these evaluations and for this data, but it really helps us continue to do this. If you have any questions about it, there will also be a Zoom link in that follow-up email. You can join me on Friday at 10 a.m. or 2 p.m. or Monday at 2 p.m. And we can walk through the evaluations or the data together. So,
Thank
yep,
you.
please jump on if you have questions. That's also my email address, or you can reach out to John as well.
Okay, thanks. And then I just wanted to put up the slide again, just to remind you to make sure you take care of yourself this week. Find some way. You can't make more time, but you can be more creative or do some acts of kindness or rekindle some old relationships and do something that will bring some joy into your life. You guys certainly deserve it. Okay, and so that's it for today. We are really glad you joined us, and I'm really glad you had lots of questions. And so, yeah, and we'll have another opportunity next month.
Thanks for having me.
Thank you so much.
Aloha, everyone.
Okay, bye. Thank you so much for an excellent presentation. Very
Oh,
clear.
thank you. Thank you.
All right, click on that evaluation link and get your credits. Okay, all right, thanks, guys.
Yeah, thank you.
Thank you.
Yeah.
Bye.
That's it?
That's it.
You want more?
Sure.
Thank you, Dr. Nguyen. Thank you, Hope.
All right.
Talk
Thank
to
you
you later.
guys. Have
Bye-bye.
a great one. Bye.
Thank you.